Welcome to Hepatitis Queensland's Hepatitis B webinar series. This is the first of two webinars in our series. My name is Joe Debattista, and in this webinar, I will provide an overview of Hepatitis B, the current situation in Queensland, and what we all can do to reach the national goal to eliminate viral hepatitis in Australia. Hepatitis B is often the forgotten hepatitis virus. However, we know from the data that this needs to change. The Hep B family tree has been created by Hepatitis Queensland as a pillar to begin conversations about hepatitis B within our communities and with our patients. We will explore these themes throughout this webinar. Before we move forward, I would like to acknowledge the traditional custodians of this land upon which we meet and acknowledge elders, past, present, and emerging. Both globally and nationally, the theme which underpins the work being done in the viral hepatitis sector is elimination. In Australia, we are working towards eliminating both hepatitis B and hepatitis C by 2026. Globally, the goal is 2030. We are currently on track to eliminate hepatitis C, but hepatitis B is lagging behind. Let me set the scene. Hepatitis B affects the liver by causing scarring and inflammation. You can see from this graph that liver cancer remains the fastest increasing cause of cancer death in Australia. 1 in 4 people with hepatitis B will die of liver cancer if not engaged in care. The prognosis for someone who develops liver cancer with hepatitis B is not a good one, with approximately half of people passing away within 1 year of diagnosis, and less than 20% of people surviving the next 5 years. Unfortunately, this cancer has a high mortality and morbidity outcome with limited therapeutic options, and this is why it is really important for early medical intervention, such as regular liver cancer surveillance every 6 to 12 months. So let's explore this a little bit further. Currently, there is an estimated 238,000 people living with chronic hepatitis B in Australia. Chronic in this context is long-term infection greater than 6 months. Currently, there is only 148,000 or 62% of the positive population who are actually diagnosed. As hepatitis B is asymptomatic, it is not surprising that many people are unaware that they are living with hepatitis B. However, this is no excuse. As health workers, we all need to be discussing hepatitis B with our patients and encouraging them to be tested and vaccinated where appropriate. We will talk about priority populations and working with people living with chronic hepatitis B shortly. The term care or monitoring has long been used with the hepatitis B sector. However, the terms liver cancer surveillance or hepatocellular cancer surveillance are starting to be used, as it gives patients a better understanding of why they need to visit every 6 to 12 months. More alarmingly, the number of people who are actively engaged in liver cancer surveillance is only approximately 40,000. As we mentioned, the connection between having hepatitis B and developing liver cancer is significant. 1 in 4 people who are living with hepatitis B will die from liver cancer. There are national targets for hepatitis B outlined in the Hepatitis B Mapping Report and in the Australian National Strategy for Hepatitis B 2018 to 2022. It is these national targets that will pave the way to Australia eliminating hepatitis B and are focused on diagnosis, treatment, care and immunisation. Currently, the only target that is currently being met is that of childhood immunisation at 95%. Australia has a national childhood immunisation program that sees all babies born in Australia offered vaccinations, including that for hepatitis B. This, along with the school-based catch-up program, has ensured that young people in Australia are protected against hepatitis B. The diagnosis rate, as I previously mentioned, sits at around 60%, with the national target at 80%. This is where having conversations about hepatitis B with patients to encourage more people to be tested is vital. We will touch on the priority population shortly, as these are a great place to start. In order to have an impact on the cancer rates that I previously highlighted, it is estimated that 15% of people need to be engaged in treatment and currently only 7.2% of people are receiving such intervention in Australia. The national target for care is to increase the total proportion of people living with chronic hepatitis B receiving care to 50%. Currently, the estimated number of people who are actively engaged in care is only 17%. So when you start to look at these figures as an entire picture rather than standalone percentages, you can see that we need to firstly raise the profile of hepatitis B and engage more people to be tested and ensure that those with a diagnosis of chronic hepatitis B continue to be engaged in care. Research also clearly indicates that those people who are informed of and are involved in the testing phase are more likely to stay engaged and take a proactive approach to their health and management of their hepatitis B. Hepatitis B does not yet have a cure, so testing, liver cancer surveillance and prevention are key. At a glance, this graphic gives you a national picture of the populations that should be considered when talking with communities about hepatitis B. Most notably, you will see overseas-born people from Northeast and Southeast Asian, European, Sub-Saharan African, and Northern African communities making up over 50% of the positive hepatitis B population. When we consider the Aboriginal and Torres Strait Islander population, the proportion of 11.2% is also significant. Here is the full list of priority populations. It is a large group. However, these people form the focus of the work being conducted around Australia and Queensland. National prevalence of hepatitis B is approximately 1%, with Queensland having a slightly lower prevalence of 0.86%. However, regions including the Northern Queensland, Brisbane South, and West Queensland primary health networks have higher than average prevalence rates, highlighted in the dark blue in this graphic. There are large numbers of Aboriginal and Torres Strait Islander people and people from culturally and linguistically diverse communities, including those born in China and Vietnam, living in these regions. I will next talk about some of the cultural considerations when working with people living with hepatitis B. Many of these will be relevant to other health issues, but it is also good to take a few moments to reflect on the needs of the communities that we are working with. Hepatitis B is a health issue that for many communities and cultural groups is wrapped up in stigma and discrimination. For example, in some countries, simply having hepatitis B can impact on employment and relationships. In some African languages, there is no word for hepatitis, making it difficult to begin this important conversation. Additionally, many languages are only verbal and there is no written form, so this is a consideration when we are providing paper-based resources. Confidentiality is another important factor for patients with hepatitis B. Many people who are living with hepatitis B are from very small communities, and therefore confidentiality may be a contributing factor to their reluctance to engage. Also, consider the family context, such as, everyone in my family has hepatitis B, it can't be that serious, or there is no family history of hepatitis B, but a long history of family members dying of liver cancer. These are great starting points for discussion around hepatitis B. And I'm sure these are just a few. There aren't any answers for many of these, more so factors to be aware of or to be prepared to have conversations about. One service to consider when working with patients from culturally and linguistically diverse backgrounds is TIS National. TIS National provides interpreter services and can be a great way to overcome language barriers. These services can be booked for an interpreter over the phone or from another state, or on site, and so can help to reduce the fear of disclosure and gossip that may occur from a local interpreter or a family member who has been asked to interpret. Now I want to come back to some of the facts about hepatitis B. Hepatitis B has 3 routes of transmission: blood-to-blood contact, sexual contact, and vertical transmission. Risky activities that fall into the blood-to-blood category include sharing injecting equipment and being injected by other people, unsterile tattooing or piercing, contaminated blood from transfusions and other medical practices, unsterile cultural or traditional practices, sharing toothbrushes, razors and tweezers, sexual activities including penetrative sex, either vaginal or anal, and unprotected oral sex when there are open cuts, sores or ulcers in the mouth. Vertical transmission or mother-to-child transmission, while reasonably uncommon in Australia, is still important to consider, as Australia has a large population born overseas, as we previously outlined. We will explore the guidelines that need to be followed for hepatitis B positive mothers in a later slide. Hepatitis B is not transmitted by social or close contact, including shaking hands and kissing, providing personal care such as bathing a person, sharing toilets, food and drinks, or even eating food prepared by someone living with hepatitis B. Blood transfusions and medical procedures in Australia also pose no risk, as all blood and blood products have been screened for hepatitis B since 1972 in Australia. The situation would be different in countries where there was lower standards of healthcare. The natural history of hepatitis B varies depending on the age of the person when they come into contact with the hepatitis B virus. Adults who are unvaccinated and come into contact with the virus will clear the virus in 95% of cases. These people do not have hepatitis B, only the antibodies to the virus, and this will act like a vaccination and prevent the person from contracting hepatitis B in the future. The situation is quite different for babies born to hepatitis B positive mothers. If nothing is done during pregnancy or at birth, there is a 95% chance that the baby will become hepatitis B positive. However, if the mother is receiving care during her pregnancy, a few different things should occur. Mum can be prescribed treatment during her last trimester to reduce her viral load and therefore reduce the risk for baby if blood-to-blood contact occurs. Secondly, baby must receive the first vaccination and the hepatitis B immunoglobulin or HBIG within 12 hours of birth. Ensuring that baby has had their first bath is important as well. By ensuring that these factors occur, the chance of the baby becoming hepatitis B positive changes to only 5%, which is a significant drop. It is in underdeveloped countries where mothers may not be engaged in care or don't have access to medical intervention that we see babies contracting hepatitis B at birth, and why the global statistics for hepatitis B are so alarming. It is important to consider also that the longer someone has the hepatitis B virus, the longer damage is occurring to their liver. A person is never too young to be in care for their hepatitis B. Regular checkups are important for everyone, regardless of their age. To reiterate, people who naturally clear the virus during the acute phase will go on to have an antibody to hepatitis B, and that will protect them from contracting hepatitis B in the future. Most people living with hepatitis B will be asymptomatic or experience mild symptoms that don't have an impact on the quality of life. People may experience some fatigue and tiredness, loss of appetite or nausea, especially after eating fatty foods, or pain or discomfort around the liver. The more significant symptoms of jaundice, dark urine and pale feces will occur as the damage to the liver progresses. Conducting a good history when speaking with patients is key to identifying people who may need to be tested for hepatitis B. Often it is reported that patients are self-managing or seeking support from their GP to manage these sorts of mild symptoms before testing for hepatitis B is considered. Many of these symptoms can present in a wide range of illnesses, and therefore hepatitis B is often overlooked or not considered. Vaccination is the #1 prevention strategy for all people, except if you are living with chronic hepatitis B. As I mentioned previously, Australia has a fantastic infant vaccination rate of 95%. However, the adult rate is lower. Adults often only consider a hepatitis B vaccination prior to travelling and often don't complete the full course of 3 injections, which are required over a 6-month period. Or often vaccination is only completed as an employment requirement. If people are unsure if they are vaccinated, they can ask for a simple blood test from their doctor. Having conversations with communities about vaccination is essential to reducing the rates of new infections. Many communities have fears around immunisation, and it has been reported that some African communities believe that vaccination provided to children newly arrived in Australia is a cause of their bad behaviour or issues around adjustment. Always be culturally considerate when discussing vaccinations. The hepatitis B immunoglobulin, or HBIg, was discussed previously for use for infants born to hepatitis B positive mothers. Its other use is in the case of a potential exposure. There is a strict set of guidelines governing the use of HBIg. However, ensuring that the community is aware of its availability is very important. HBIg should be administered within 72 hours of potential infection and can be accessed from GPs, hospital emergency departments, and some sexual health clinics. As set out in the Australian Immunisation Handbook, there are particular at-risk populations who are eligible for free immunisations for hepatitis B. You can see these clearly outlined in the slide. If you are seeing any patients from these communities, please start the conversation about vaccination. Testing for hepatitis B can be a barrier for clinicians, and interpreting test results can be complicated. However, there are some fabulous resources available to make it an easier process for all. This particular fact sheet is available through Hepatitis Queensland's website, and it highlights the tests which need to be ordered and how to explain this in simple English. It also explores the prevention messages, such as ensuring the family and sexual partners are vaccinated as well. On the reverse side of this fact sheet are the tests which need to be ordered and a simplified table of how to interpret the serology. This is also a great tool for talking through these complex factors of hepatitis B testing with patients. Along with the previous testing fact sheet, the ASHM Decision Making for HBV is a great resource for clinicians. This particular tool highlights not only who should be tested, but the exact tests which need to be ordered and how to interpret these tests as well. On the reverse side are the phases of hepatitis B and the factors required for treatment. We will explore this further in our next webinar. These 2 different fact sheets can be used hand in hand to cover all bases when talking about testing. There is currently no cure for hepatitis B. However, there is much research being done to find a cure. The treatment for hepatitis B aims to stop or reduce replication of the virus. With less virus in the blood, less inflammation is being caused in the liver and therefore less liver damage. This makes management the focus. Every person with chronic hepatitis B needs to be engaged in care. As we previously mentioned, ensuring that patients are being monitored every 6 to 12 months will significantly increase the chances of any changes to their liver being detected early. Liver cancer surveillance can be done with a GP or through a tertiary centre and requires blood tests and an ultrasound. The treatment are tablets taken daily. However, not everyone living with chronic hepatitis B will need treatment. Encouraging patients to continue their liver cancer surveillance, as well as ensuring they maintain healthy lifestyle factors to keep their bodies strong through diet and exercise and lifestyle, can be a great way of motivating patients to actively engage and manage their hepatitis B. Hepatitis Queensland's Treatment Directory, or HepNav, provides a navigation tool for patients to find a range of doctors providing treatment, FibroScan locations, as well as pharmacies that dispense the medication. It is a very simple tool to use and is being updated all the time. There are also a great range of hepatitis B resources available through the Hepatitis Queensland website. We will demonstrate how to use many of these in the upcoming webinar. That brings us to the end of our first Hepatitis B webinar. We would like to thank you for watching and encourage you to start the conversation about hepatitis B with the patients who you are seeing in your service. As I have mentioned, there will be a follow-up webinar coming soon which will explore further the hepatitis B treatment space and what a good interaction with a client could look like and how to incorporate all the information and resources effectively. I would also like to encourage you to subscribe to our newsletter called Special Delivery or follow us on your preferred social media platform. If we are all talking about hepatitis B, we will increase its profile, and in turn, that will have a great impact on our ability to eliminate viral hepatitis from Australia.